Can I ask a question here, Greg?
Yeah.
So the ACA got involved with dual eligibles. They created a new agency to coordinate Medicaid, Medicare.
Right.
And they also redefined what Medicaid status is up to 138%.
Right.
Can a person say that in those states that adopted new Medicaid rules that you're not likely to have spend down, or you are likely to have spend down?
So there's really no necessarily correlation. The reason I say that is this. So one of the parts of the law that most people didn't read is when you expand Medicaid, in order to, like Ohio did, for example, right? So Ohio took the money to expand Medicaid. So as soon as you turn 65, or as soon as you are disabled for 25 consecutive months and qualify for Medicare, you no longer are allowed to be on Medicaid because you have the expansion. So if it was 138% under the new law, once you qualify for Medicare, you now have to qualify under the original federal poverty level for Medicaid. So the expansion goes away as soon as you qualify for Medicare, right? So it was typically an expansion just to get more people into Medicaid. As soon as you became a Medicare eligible, you no longer qualified for Medicaid under the expanded federal poverty level requirements.
Do people understand that, or are we getting too far off track in terms of these numbers?
The reason we bring it up is because it happens a lot in Ohio. Is folks will go and they'll want to sign up for a DSNP, but they'll be on this expanded program, but they haven't gone back to the state to say, hey, I'm now eligible for Medicare. So the state says, if you see one of these people, deny their enrollment, and you need to let them know they need to go back to the local Department of Social Services or Medicaid office in Ohio to get redetermined under the original state Medicaid rules. So we can't enroll folks, which Ohio calls them MAGI 8, which is Medicare adjusted gross income. Excuse me, modified adjusted gross income. So I guess it's technical, but you guys will run into a lot of this stuff because why don't I qualify? I'm on Medicaid. Well, because you're under the expansion program. If you don't go back to the state and requalify, you're not going to be eligible for a DSNP program. Right.
But that's not the case in Indiana because we did away with our spending.
Right. Well, you did away with the spend down, but you didn't take the Medicaid expansion dollars, so it would not apply to Indiana. But states, to Edgar's point,
I thought it was gone.
Yeah.
Right.
the states that yes, so they eliminated theirs like 2 years ago. Ohio's eliminating theirs now. But to answer your specific question around Medicaid expansion, it doesn't apply to dual eligibles. It was only to get more folks under Medicaid. Once you qualified for Medicare, you had to qualify for Medicaid under the original rules.
Let me know.
So real quick, this is important. It talks about how does the spend down work. Again, this is for, you guys can take it away, look at it at your leisure. Essentially, you are identified with a dollar amount, and then you have to spend those on qualified services. You can't just, so like New York, you can write a check back to the government for the entire amount if you would like. Most states make you spend it on services, healthcare services.
Ready?
Yeah. Okay, so how does a dual eligible become a member of a DSNP plan? So essentially, it's what we talked about. Dual eligible applies for Medicare, Medicaid, whatever piece is missing. State determines, or CMS determines that they're eligible for the program, Medicare or Medicaid. They're notified, and typically they'll get something in the mail. And I know that you guys experience this. They don't know where their award letter is. They don't have any of that paperwork, so they don't know what level they are or what they receive under their Medicaid benefits. But they know they are a Medicare eligible. We get proof of eligibility, we sign up an application, and then we work with the member and their caregiver to coordinate and manage care. So we don't just get extra money to service these members. CMS pays us about, on average, $250 to $300 more for a dual member than they do a member on our sort of regular standard Medicare member, because there's additional requirements that we have to do. We have to have a care plan, we have to get them assessed within 90 days of enrollment. There's a whole host of requirements that we're required to do to manage them as a dual eligible member. And so that's why I mentioned this here is, hey, we do have to work with them and coordinate with them as soon as they enroll in our product. So characteristics, approximately 1.3 million of dual eligible population enrolled in DSNP. That number continues to grow as they become more, I think, stable. Because plans are looking for these to be solutions. As Medicare reimbursements have come down, duals have been more and more popular because of their higher level of revenue and reimbursement. The majority of DSNP enrollees are full benefit dual eligibles. Does anyone know what a full benefit dual eligible is? So it means they have full Medicaid benefits and full Medicare benefits. So typically you'll hear partial dual versus full dual, and we'll get into that in another slide, so I won't get into it here. But essentially full benefit dual eligibles are those that are eligible for the full suite of Medicaid benefits. So we talked about this, a recent study talks about fee-for-service, those in MA plans, significantly higher proportion of younger disabled Medicare Advantage enrollees are in DSNPs. So younger than 65 and they're getting Medicare because they're disabled, they're more likely to choose a DSNP. And that's sort of, for me, logical to understand because they're more familiar with managed care versus used to being in fee-for-service, Medicare for some period of time. Significantly higher proportion of racial ethnic minorities are in DSNPs and other MA plans. We can probably guess as to why some of these things are. Again, duals are typically more concentrated in urban areas. That's where we sell, that's where we market, and that's where the majority of these folks are living. Higher proportion of enrollees, we talked about this, with chronic mental disabled condition, right? So they have 4 to 6 chronic conditions that they're dealing with at any given time. Okay, so this is important. So types of dual eligibles by market. So, and I hate the point, but, so if you guys can't read this, it says FBDE, QuimB Plus, QuimB, SlimB Plus, QDWI, QI. Does anyone know what those categories mean?
Different Medicaid
Right,
categories.
correct. So these are called the Medicare Savings Program categories. And some of them are optional, so states don't have to have a category. Like, for example, SlimB Plus doesn't exist in every market. Florida doesn't use it, Hawaii doesn't use it. There's a number of markets that don't use it. And typically that's why if you see a no here, it's either because they don't have it or they're doing something special with these types of folks. So FBDE is full benefit dual eligible. It's a category, it doesn't necessarily mean what we were talking about a second ago. It's literally a category of members that also will have full benefits, right? QuimB Plus is a qualified Medicare beneficiary. You know what the plus means? Plus Medicaid, right? This stuff is like simple when you start to kind of piece together what they're trying to do. So qualified Medicare beneficiary, and then the plus sign just means they have plus they meet requirements for Medicaid, so they get the full suite of Medicaid benefits. QuimB qualified Medicare beneficiary, they're considered partial duals because they don't get full Medicaid benefits. They get cost share coverage as well as Part A and Part B paid for by the state, but they just don't get the Medicaid benefits. So if they were went to a nursing home, for example, it would not be covered by Medicaid. There would be out-of-pocket costs for that particular member. SlimB Plus, same thing, specified low-income Medicare beneficiary. Plus means they have full Medicaid, and then QDWI is a qualified disabled working individual, and then QI is a qualifying individual. So those are typically partial duals that get Part A or Part B paid for depending on, they wouldn't be right for most plans DSNPs, because we typically enroll these 4 categories because they don't pay cost share, right? So when you look at a DSNP plan, it always says 0 in terms of what the member's responsibility is for cost share. That's because we only enroll those 4 categories who are not responsible for paying any out-of-pocket costs.
Right.
Right? Makes sense? And the agreements, you don't have to pay attention to those. That's just it's the type of contract we have with that particular state, whether we're providing services on behalf of the state or not. I don't think we have any slides on here on that, so. All right, so benefits of an Anthem DSNP product. Medicare A and B benefits are filed the same as Medicare fee-for-service. What that means is we file with CMS to pay 80% of the member's costs, right? So again, the materials the member sees and you all see say 0, right, for member responsibility, it doesn't say 20%. And the reason that is the CMS knows by the nature of the product, so that when we file at 80%, they know that the Medicaid plan, either Medicaid health plan or the state's Medicaid will pay that remaining cost for the member, so the materials automatically print at 0. So most plans, and I would say probably 95% of the industry, file 80% on the Medicare A and B benefits, right? So it's typical medical benefits. Their materials show 0. And they use the savings from those dollars of not having to create co-pays and make it more attractive. Use those dollars to provide supplemental benefits, and that's why typically you'll see DSNPs are so rich from the supplemental benefit side, is because we're not spending money to create a $5 PCP copay, right? We can file 20% and the state will pick up the rest. Part D is included in the plan. It's an it's an MAPD product, so it was always Part D, and typically the members will not pay any higher than the low-income subsidy amount per drug tier. Right? Sometimes we'll be better than the low-income subsidy. We'll have the $0 on tier 1, for example, but the most they would ever pay out of pocket is whatever the low-income subsidy amount is for that particular drug tier. Right, so we talked about this, right? Supplemental benefits designed to align and expand upon services they receive under Medicaid. And so there's a lot of research that goes into what each state covers and why, and how we're able to sort of best support those types of products. What we will typically see is dental, hearing, vision, because it is covered under Medicaid, but again, in different ways, depending on age or medical necessity, right? We'll have sort of a standard package of dental, hearing, and vision, at least some level of all of those. OTC catalog and card, there's a mix. I can't speak to Indiana.
Indiana and Ohio are catalog, Kentucky is the card.
Okay.
And
So,
I'll talk about that a little bit too.
yeah, so it's a good mix. You can order either through the mail, and then I think actually Kentucky has card and catalog. If you have the card, you have a catalog
Yeah, you have
too.
both.
Yeah, so it's a good dollar amount because it's free money for them to go and buy the items that they want to buy in the store. Obviously, it's a limited list of things. You can't buy booze, unfortunately. But it's a good, one of the things is we see is this is one of the most sought after benefits is the OTC amount, because it is sort of money for them to be able to spend at the stores that they shop in. Transportation is typically covered under Medicaid, but again, if you're a Quimby member and you're in our plan, you don't get that Medicaid transportation. So that's why you'll see we'll offer some level of transportation on all of our products. And so it is still attractive to the members that wouldn't receive that under their Medicaid benefit. And then Live Health Online, I don't know if anyone's ever used it. I have. I absolutely love it. When I'm sick, I don't want to get out of bed and go to the doctor. I just pull up my phone and I have a doctor in a couple of minutes on my phone. He sends a prescription to the pharmacy that's 200 yards from my house, and I go and pick it up. I don't know, anyone ever used it? I mean, I don't know if your experience was similar, but I've never waited more than 5 minutes for a doctor, which is more than you can say when you go into the actual office. And they're sort of in their office or at home, and within half hour my prescription's ready at the pharmacy. So I have 2 small boys. I've used it in the middle of the night, 3, 4 in the morning, when one of them has had a fever. Within a minute or 2, I have a doctor on the line. We're able to have sort of conversation and what we need to do. So I love it. We don't have a ton of people that are using it today. It is growing as more folks, more of the seniors have access to the internet and are using, are more comfortable with it. I think that number will go up, but I absolutely love it. And I don't know if you
use it all the time.
Yeah, it's really great. And so if folks can understand it, I think, and be comfortable with it, it's really a great tool. It's on every market except for Texas, because the state doesn't allow e-prescribing. So it doesn't make sense if you can talk to a doctor and then he can't write you a prescription for anything. So we just don't have it on our Texas plans. But everywhere else, we actually just added it to New Hampshire because the state passed a law allowing for online prescribing.
And we have it in Indiana, Ohio, and Kentucky.
Yeah, it's on every plan except for the ones in Texas. All right, so here's like really important stuff, and I forget the lovely woman we were speaking with beforehand that was asking this.
Aaron?
Yes, this question, right, about plan IDs, right? So one of the #1 complaints I have, besides the one I mentioned before, is about DSNP and balance billing, right? So I went to my doctor and he's charging me $20 for this office visit. Well, did Dr. Smith know that you also are a Medicaid member? Well, I don't know, right? So whenever you go to the doctor, it seems logical to us, right? Present all forms of coverage that you have so they know the proper way to bill. Medicare is the primary payer on pretty much every service unless it's some sort of long-term care where you're in an institution or getting waiver services, right? So when you go to the doctor, always provide the Medicare card and then any other Medicaid card that you might have, whether that be an Anthem Medicaid card if you're a member for both of our plans, if it's a United Evercare Medicaid card, if it's WellCare Medicaid, or fee-for-service, the state's Medicaid card. Excuse me. You have to present those each and every time because the billing folks essentially run the office, right? It's not the doctor that's billing you, it's the billing folks that may not know that you had, other coverage. And I deal with it all the time, and I'm in the industry calling billing folks and saying, I have an HSA, it's on file, like, or you can't bill me for my wife's services, like, that's not how that works, right? Because you can only pay your HSA out of, for certain people, it has to be your name. So they just need all that information up front, and so if you don't present those IDs, you're gonna get something in the mail that says, you owe us X amount of dollars, because they didn't even attempt to bill the state. The other thing I would say here is, most states require the provider to have a Medicaid ID, right, to bill the state. Now in Florida, you can get what they call a billing ID, because one of the number one things doctors say is, well, we don't want these folks in our waiting room, right? We don't want to treat the Medicaid folks, that's why we don't participate. In Florida, they allow you just to get a billing ID, so you're not listed in a Medicaid directory as a Medicaid provider. You can just, for dual eligibles, you can bill. Not every state does that. So what I encourage your folks to do, and when you're educating them and enrolling them, is tell them, pay attention to the directory. The directory has identifiers for providers that take Medicaid. We're required to put that in our directory, so if you need to go see a specialist, right, try to, if all things being equal, pick one that has Medicaid, because that will drastically reduce the issues you have with those providers. Now, no provider's supposed to balance bill. They know that, it's in our contract, it's federal law that you can't balance bill, right, these folks, but they do, and there's only so much that you can do in terms of education. Folks, to some degree, are going to try to collect as much money as we can. We educate them, other competitors try to educate providers. The only thing you can do is term the provider or continue to try to educate them. So what I always encourage folks when I'm talking to groups like this is, show both your IDs, and when you're looking for a doctor, if there's no, all things being equal, if you need to go to someone that accepts Medicaid, because that's gonna make your life a million times easier, and that's all in the directory, both online and the printed version. There's identifiers that show you which providers also accept Medicaid.
When you say show your Medicare card, you're talking about your dual special needs.
Yeah,
not
our
your
ID,
Medicaid.
right, whatever your Medicare provider card is would be us or whomever.
Plan ID. Yeah.
Right, show your plan ID, right?
They have to accept Medicaid, don't they? Really?
So,
How does this work? You want the provider to accept Medicaid?
correct,
Yeah.
right, yeah, and so we do a lot of education on that, but again, as your networks get broader,
Yeah.
especially Anthem, we have a large commercial network that then also does our government programs, and so there's not a ton of overlap between your commercial providers and those that take Medicaid. Because again, one of the largest issues that we always run into is, well, we don't want those people in our waiting room. I've heard that from doctors, in Louisiana, in New York, and Maine, anywhere you go, there's some of those doctors that just, we want a certain clientele in our office, and we'll take you because you're Anthem, Blue Cross, but we don't want to see the Medicaid folks. And so what I say to that is, okay, but now you can't bill these people, right? It's in our contract, you sign a contract, it's against federal law. Most of them are good, but you're gonna run into those folks that are gonna try to balance bill, and so this is the way that you try to prevent that as best you can, is to educate, present both cards, and then also, if you're picking a provider, there's not one you're tied to, from a specialist perspective, go to one that accepts Medicaid, your life is gonna be a million times easier, and that's why we do those things. Yeah.
But being an HMO, you have a specific network you have to be with, and not every doctor who takes Anthem has to take the DSNP plan, correct?
So typically that's not correct. So if you're in our HMO, DSNP is an HMO, you're in our HMO network. We've had some providers that have said, mainly in California, we only want to be in your DSNP network, we don't want to be in your HMO. That's really where their specialty is. And others have said, we only want your HMO, we want a DSNP.
But if you have providers in your PPO who say we do not want, they can't be in your PPO and your HMO and say no DSNPs. They have to take the DSNP at that
Correct.
point. Okay.
Yeah, I mean, they can try to opt out, and we work with them, but we try to educate them on why DSNPs are good for their business, and it's where the future of healthcare is going, right? Again, you saw those numbers, 13 million of them, there's only about 1.5 million in a DSNP plan. Those numbers are gonna continue to grow, and so we try to educate the providers and saying, your future of your business is in this population, because every state is trying to solve for it. Most of my traveling is literally helping states solve for duals. I'm supposed to be in another state next month. I was in another a state in the East region a couple of months ago. I was just in Indiana last month. As they start to tackle what they're going to do with these programs, it's going to be more important for providers to participate. Oh, sorry, Keith. Yeah.
Well, two questions. Number one, is there ever a way to be able to use urgent care? And number two, are you reaching out to the hospital chains?
So, first question is, can you use urgent care? The answer is yes. That's always a covered benefit for us. For duals, it's a zero cost share. And most of those take Medicaid because of the nature of the population that they kind of see. And then your second question was, do we reach out to the hospital chains?
Yeah, are
In
you
what
talking with the
way?
hospitals? Identifying which of them have doctors that are willing to accept Medicaid.
Yeah, so
In fact, I think there's one chain here in town that all the doctors have to.
yeah, so that we've seen some of that. We've also seen what we're trying to do is one of the other things that we're trying to do and other companies are trying to do, right, from a provider perspective, is get more in what we call risk sharing arrangements, so that they're sort of more involved, and Edgar talked about this in the beginning. HMO is the future because you're getting more folks to take responsibility over their network. So if you're this hospital chain and you're all doctors taking Medicaid, you're a perfect partner to talk to about doing a dual eligible plan, centered around them and them managing those members and being the patient-centered medical home, right? So they coordinate the care, they do the health risk assessments. Those conversations are always happening. Being a large provider like we are, especially in New York, we have a lot of these relationships already in place where their doctors take Medicaid, they're at risk for managing patients' care. So yeah, those conversations happen all the time. We have our VP of network for the central region, and that's essentially what those guys are doing on a daily basis is going out and trying to get those types of arrangements for us as a healthcare company.
And one more thing, I need to ask this because we run into it all the time as independent agents. Is Anthem having current or captive agents out marketing these programs in the communities?
Of course, yeah. Yeah, we have, I don't know how many, but we have a captive, pretty much captive agents in every one of our, in our markets that also sell this product. Now, we try to do, and I can only speak to the East region, what we try to do is try to make sure that where our agents aren't, the brokers can also go, right? If we're at a certain Walgreens, the other Walgreenses are available for those folks as well, right? So we try to more have a relationship where it's collaborative, and I know that's improving over time, where it's not this adversarial relationship between internal folks and external folks, but it is an ongoing process.
So I have a follow-up question on the networks. I got onto the Family Social Services website for Indiana Medicaid, and I did a provider search for Hamilton County and for Lake County, and I was surprised to find how many doctors did accept Medicaid. If you do a provider search on the Medicaid website for Indiana, for hospitals, let's say, let's start with hospitals.
Right.
Does that mean automatically that those hospitals are in network for Anthem?
No, so if we have a contract with them, they would be in network for a DSNP, right? So if they're one of our contracted providers and you search our directory, the easiest way to do this is if you go to our online directory, type in whatever hospital you want, it'll have an indicator that says accepts Medicaid, and they'll be in our network. So you would be able to go to them under the DSNP plan, and we would,
So to be safe, you use our online store tool. You go in there to search, and that way when you pull it up, you're gonna see what doctor. If you look up a particular doctor, it's gonna say in network for HMO, SNP, RPPO, whatever the case may be.
Right.
And that's the best tool to use. And we have printed versions of the directory, which are fine, but everybody knows it can change on a day in and day out basis. So if we have time today, I was gonna try to pull up online store if somebody hasn't used it and show you what one of those look like. But that is the best source to look
that has
at.
identifiers also about they're in they accept Medicaid, because I know, so I'll get to you in a second. So every month we have a file exchange with every one of our states that we do business with. It's one of the things that's in our contract that we negotiate is the state has to provide us a list of their providers monthly. So we're constantly updating our online directory to make sure that nobody turned from Medicaid, no new doctors came on board, because we want those folks to have the most accurate information as they're picking doctors.
So as a reverse to that, then,
Yeah.
if they are in the HMO network, then it means they're on Medicaid, right? Or they take Medicaid, excuse me.
No, it's not a one-for-one. That's what I'm saying, that's why you need to look for the identifier. Not every HMO provider or DSNP provider takes Medicaid. We encourage that, but it's a decision that each doctor has to make on their own, and that's why we get the file from the state to be able to match our docs with theirs.
I mean, your HMOD SNP network,
Right,
they will all take Medicaid?
not all, no.
No.
No, because what we use is we use the HMO as a starter, and then we say, we're gonna, because DSNP's an HMO product, and that's why we have to do the,
So we'll just.
We're in the
Emerging.
process of trying to work with them to
Okay.
open that up and make that more expansive, but you can't have a blanket statement that,
Assume that.
yeah,
Okay.
exactly.
Look 'em up.
because then don't
Okay.
forget, and this is a really good point, and I need to get to him, but the question, one of the issues is,
Him,
you can't meet Medicare requirements,
him.
we're just
Wow.
Medicaid providers. There's not enough of them. Medicaid requirements are a lot less stringent and strict. So when you're building a Medicaid network, you can do it at a much faster pace and in a quicker period of time because you need lesser of them. CMS has very stringent time and
They're no
distance
fun.
rules. Yeah, so if you took if you took like our compliant Medicaid network in Florida and compared it to a compliant Medicare network, it would not even look close.
Okay.
Because the rules are just drastically different between state and feds, and that's why you end up having doctors that aren't Medicaid, because you just physically need them in order to meet adequacy for the product. Even though they might cause more issues for members, that's CMS rules and requirements, is you still need to meet the broadest terms of the network.
2 questions.
Yeah.
One, do you have the IU Health Network?
Yes,
Oh, good, I do.
yes.
You sell the DSNP in Dearborn County, I noticed, which is Lawrenceburg down the southeast. Will that cross over to Ohio?
No, so HMO products typically, we won't cross over unless we need it to meet adequacy, and at some point we'll add in some of the docs across the border if we can't meet adequacy in just in that county. Because as a Blues plan, you can only contract one county into the next state. It's a rule that the Blues have. Even though we're the Blues plan in Ohio, it's still the same rule. So it so you may have some doctors that are in Ohio because we needed it to meet CMS adequacy as we just talked about, but it's not, you can't go to any doctor in the next county, in the next state.
The hospital in Lawrenceburg is Dearborn County, whatever,
Right.
is now affiliated, I believe it's with Christ Hospital. I believe it's that one. Would they be able to use Christ Hospital because of that?
It's a good question. It probably depends. I'm assuming once our contract works with them and they become a network, we just gotta figure out if we've added it to the plan or not. I have to go back and research that because it depends on what gets added to that plan as an affiliated hospital.
So we could look on,
You can look
on
online.
store
I
and
was just
see
gonna
that
say, the
information.
easiest way, honestly, to get your
Yeah.
answer would be to go
Go online,
online and
yeah.
look that up,
Yeah.
yeah.
Okay,
Yeah.
thanks.
And you-
So I'm a client and I go on your network and I see that this Dr. Jones is in network for an HMO, for my plan that I have, but he doesn't take Medicaid. I go in and see him because I, as a client, don't know to look for that.
Yeah,
Who's paying my 20% that's left over if he doesn't take Medicaid? Because you just showed me in your book that I pay nothing.
okay, so with every one of our providers, we have an agreement that they must accept our payment as payment in full. Federal law says, and it's the Section 9 of the Social Security Act. I know way too much of this stuff, but, so, Section 9 of the Social Security Act says you're federally prohibited from balance billing the categories that I showed you, right? The folks that are covered by the state, by law. It doesn't matter that you don't take Medicaid. That was a way for states to just pay less providers, right? by
So
saying-
as agents, we need to tell our clients, you do not pay any bill you get.
Correct.
Call me, possibly I can call your doctor and explain this to them, but
Correct.
do never pay a bill on this
Correct.
plan.
Correct, because in our contracts, in every plan, we're required to have the statutory language for duals plans that says, you must accept our payment as payment in full. If Medicaid owes you money, not our problem, not the member's problem, you don't take Medicaid, they're not responsible for it. You agree to the rules of our plan, and we would love to have that information, right? Because we want to be able to go out and support the efforts you guys are doing, educating those providers to say, hey, you're gonna have to eat this. And most times, states have lesser of rules, which means they pay nobody anyway. So if Medicare, right? So because but it's the truth, right? So if you have a claim, let's say it's $100, Medicare pays $80. The state fee schedule may be you get $50 for this service. They'll say, well, Medicare paid you $80. We were only going to pay you $50. You got more than you would have got anyway. We're not giving you a dime.
Okay.
So out of the 50 states, 43 of them operate this way. And of course, New York is one of the oddballs where they pay 20% of 20%. And some people get 100% and it's carved out because they have lobbyists. So there's all these little rules that you have to know. But for the most part, they would not get any more money.
It's just more on a client's side
Right.
when they're getting a bill and now all of a sudden your insurance company.
Right. And don't forget, the billing folks don't know a lot of this stuff, right? I mean, I've been doing this for a really long time. I know all the ins and outs. They may not. They could be new. Who knows what experience they've had with dealing with this. And so that's why we're constantly trying to do that education. We're required to do education yearly, so we do that. And we'd love to support your efforts to the extent that you run into provider balance billing. That's something we definitely want to know about.
So are these plans a replacement for MCOs or in addition to MCOs?
So this plan, some Medicaid MCO, you mean? So this would still be like a wraparound. So in Indiana, duals are excluded from managed Medicaid. So if you're in a Anthem, right, Medicaid plan in Indiana, which is possible, you're not a dual. The minute you become a dual eligible, you go to fee-for-service Medicaid, the state pays all of your claims. So
Okay.
that goes back to what I was talking about. A lot of these states are starting to look at, what do we do with duals? How do we know they're 40% of our costs. How do we align the care, right? Knowing that Medicare is a program, Medicaid is a program, all the issues we talked about today, how do we solve those to the best way possible? But yeah, so today, if you're a dual eligible, you're not gonna be in an Anthem or a forget the other name of the company.
So in Kentucky though, there's.
Kentucky, yes, you could be both Anthem members for Medicaid and Medicare. You could be a WellCare Medicaid member and an Anthem Medicare member. But yeah, they're not mutually exclusive.
Okay, so if I run into somebody who has WellCare or Coventry Care, I can get them this, and they have both.
They have both, yeah.
Okay.
And they would just do the same thing. They would present both cards. We would pay the Medicare claim, and then the doc would then take the payment and send that over to whomever is the secondary payer, right? Whoever the Medicaid plan is.
Right,
the
so
doc.
this is primary and then the Medicaid would be the secondary.
Correct,
Okay.
yeah. So, that's how it works in Kentucky. Each state is different. That's why I said these products are a little bit confusing, because in Florida, if you enroll in a DSNP plan, you no longer have Medicaid. All of your benefits are provided by the DSNP, right? So there's this exclusivity. You can't be on both. You have to be on Medicare plan or a Medicaid plan. You can't be on both. Yeah.
Sorry, jumping back to Aaron's question, when we had the folks that got billed for $20.
Right.
And if they're on the dual special needs plan, what if they're on a regular HMO plan, it's not dual special needs?
So that's where it gets tricky, because if you look at the Medicare Managed Care Manual, what it talks about is states have the option of covering Part C cost share, and because if we go back, can we go back a couple slides to where it had the contracts on it, it has the Quimby's and all that stuff?
By state.
Yeah, right there. So, see these things? These are the contracts we're required to sign. So under federal law, we're required to have contracts with every state we want to have a DSNP in, right? So those contracts outline all the requirements that we've agreed to and the states agreed to in terms of payment and everything else. When it's a regular MA plan, states don't necessarily have to pay because there's no agreement, right? It's an option if they want to pay and cover Part C costs. So what I always suggest is, provide ID. No matter what plan you're on, provide your Medicare, Medicaid ID. Typically they'll pay, but I don't like to give a blanket answer because you never know. There could be a quirky state that's out there that has an issue with it, but typically they'll pay. Because again, you're federally protected. It's just that some states don't honor the fact that you don't have an agreement with them and whatever else. But if you just provide your Medicaid card, Medicare card, or plan ID, most states will pay that if there's any money owed to the provider. Now again, they may send them a thing that says, we're giving you $0, and so the provider then needs to eat that, because that's all you've got under Medicare anyway, right? And one thing I will note is if we have an agreement, or other plans have an agreement with a provider that's above Medicare, so you have 100, we're gonna pay you 110%, they'll get 80% of the 110%. So that sometimes, helps too. If, it's not just a $100 claim, you're gonna get 80, you might get 85.
Actually, the question.
Oh, I'm sorry.
Under the supplemental benefits,
Yeah.
what's the amount of the over-the-counter benefit? Is it monthly or quarterly or
So, right.
Well, for which state?
for Indiana?
For Indiana, it's going to be quarterly.
Quarterly?
So the easiest way to remember this, this little trick, if it's a quarterly benefit, it's a catalog. If it's a
Yeah.
monthly benefit, it's a card and catalog.
Okay,
Yeah.
so how much can they spend quarterly?
I think, do I have that on here? I think I do. I'm gonna talk about that with you
Okay.
next, actually, so hold on to that one.
Okay.
So these benefits are expensive, so one of the things I should add is that's why you'll see a lot of fluctuation year to year, is dental's really expensive, transportation is really expensive, and then OTC are really expensive. And because those are the benefits that folks want, right? They want those types of, they want the dentures and the extractions and, and that's, could be $30, that'd be $30 per member per month, which is really, really expensive when you're talking about all the other things that you're mixing in. Yep.
Do you ever go to, resources where we can go and get what Medicaid offers for each state?
Yeah, so again, you gotta love,
Specifically, because I know their website's just.
I've worked in government before, and the great thing about government, the bad thing about government is really confusing. So if you go to the Medicaid website, you have to look at what they call the provider manual, and they end up giving you codes, because Medicaid is always covered by medical necessity. It's not like a supplemental benefit where you show up and you're like, oh, I want a pair of glasses. Well, you have 20/20 vision. I don't care, I want a pair of glasses, and we would give you the glasses, right? Under Medicaid, you have to get the